Hello, my friend. Welcome to my show Chronicles of Alana RN, and thank you for listening. My name is Ratika. I'm a critical care registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today, we'll be talking about COPD, and by extension, chest x-rays. As a disclaimer, I will not be providing any personalized information. All names, numbers, and results will be altered to protect the privacy of the patient this story is derived from. As an extra disclaimer on top of my usual one, I actually have never even attempted to explain COPD to the layman. A funny story, but in my semester 1 postgrad notes, I've told myself to do it before the exam. Spoiler alert, I didn't do it. But I still passed, so take from that what you will. It's just been one of those conditions that I have been primed to know about, like oxygen parameters and stuff like that. But now having finished postgrad, that includes lung function, treatments, expected pathology results, normal versus abnormal lung sounds, it's just there in my head. But I'm fully aware that I'm going to explain in 20 to 30 minutes what has taken me about 6 years to learn and understand completely. So I'm going to try my best. And if you've got extra points that I missed out on or believe I should have explained better, or even if you're still sort of stuck afterwards, send me an email or leave me a comment. I'll do my best to make myself clearer. Without further ado, let's get into it, shall we? COPD, or chronic obstructive pulmonary disease, is an inflammatory condition, would you believe? I know you're all smart, and I know you know this already. It's very similar to asthma in the sense that it's an inflammatory condition that causes obstruction. COPD can also be referred to as chronic bronchitis with or without emphysema. The difference between COPD and asthma is that asthma primarily affects the airways, but COPD affects the alveoli. But they both cause difficulty in exhaling, hence the obstruction. The disease process for COPD is similar to that of asthma, but not completely the same. Now, before I continue, if you have listened to my episode on asthma, you'd be glad to know that I'm not going to bombard you with jargon this time, I promise. Emphysema is a structural change to the respiratory function as a result of long-term irritation and inflammation. Common risk factors include asthma, smoking history, and air pollution. So, similar to asthma, irritants cause inflammation through white blood cell response, calling on oxidants and particular enzymes to manage the irritant. But it's the chronic nature of the inflammation that degrades the elastin of the alveoli over time. Elastin is another sort of protein enzyme. Degradation of elastin leads to a reduction in elastic recoil. Elastic recoil is necessary to keep the alveoli open on exhalation. Without this, the sacs, they get saggy, I feel is the best way to put it. I suggest looking up a diagram of alveoli to really understand the gravity of a saggy sac. Basically, these sort of collapsed alveoli cause hyperinflation because they collapse during exhalation and they cause gas trapping. Inflammation and obstruction also leads to decreased forced expiratory volume, decreased airflow, and increased gas trapping. Increased gas trapping, which means gas gets trapped, but decreased gas exchange. So the movement of oxygen and carbon dioxide is decreased. So lower gas exchange means increased carbon dioxide, decreased ventilation, and increased physiological dead space, which is not the same as dead space ventilation. This physiological dead space equals an increased shunt, which is our VQ mismatch, which leads to vasoconstriction due to hypoxemia and pulmonary hypertension, which is also a pathway to heart failure, which we've been talking about for a few episodes now. Before we continue, I'd like to take a moment to clarify the difference between hypoxia and hypoxemia. Hypoxia is often used as an umbrella term for low oxygen, but this can be used incorrectly at times. Hypoxia as a definition is low levels of oxygen in the tissues and at a cellular level. Hypoxemia is a low partial pressure of oxygen in the arterial system. Hypoxia is noticeable from clinical observations like cyanosis and oxygen saturation monitoring, but hypoxemia is only diagnosable through arterial blood gases, or ABGs. You can have one without the other in certain situations. Therefore, due to all these chronic structural changes to the lungs, baseline lung function for COPD patients is already altered. These structural changes take so long that by the time the patient is actually experiencing symptoms, such as the classic shortness of breath, worker breathing, chronic phlegm, chronic cough, and reduced exercise tolerance, the damage is often irreversible. Therefore, it's the exacerbations of COPD that often cause the most issues for patients. There are two types of exacerbations, infective and non-infective. And like I said, you're all smart. I'm pretty sure you can figure out what sort of things cause infective exacerbations of COPD. You'd be correct. Viruses and bacteria. Non-infective exacerbations can be caused by irritants like allergens, ongoing smoking, non-compliance with medications, pleural effusions, pneumothorax, and even poor left ventricular function. This sort of ties in with the pulmonary hypertension, but we'll get into that later. Exacerbations just temporarily worsen the state of inflammation and worsen the obstruction, causing the increased shortness of breath, worker breathing, hypoxia, and sputum production. So what investigations do we do for COPD? Or better yet, exacerbations of COPD? First and foremost, we do a set of OBS, but we're not here for that. So we'll get into the nitty-gritty. We'll start with a VBG. VBGs are very important to check pH and CO2. The things we would be looking out for is a respiratory acidosis, high CO2, low pH. But this can be chronic, acute, or even acute on chronic. But looking at CO2 is of extremely high importance as it determines treatment and oxygen targets. We only really look at ABGs in extremely sick patients and are often only taken when an outline is inserted. Personally, I've only seen sort of a radial aspiration done once in my 3 years in emergency. Usually, if we're needing ABGs, we'll just pop in an outline so we can get multiple. Next investigation is a chest x-ray. This can help rule out infective versus non-infective causes. And common findings on a chest x-ray for COPD patients include a blunted costophrenic angle, indicative of barrel chronically hyperinflated chests. Next investigation is an ECG. Would you believe? ECGs can help determine right heart strain by looking for right ventricular hypertrophy, P pulmonale, which is right atrial enlargement, right axis deviation, a right bundle branch block, ST depression, or inversion in V1 through to 3. Now, how does a respiratory condition cause all those problems in the heart, and how can we see that on an ECG? So these are all compensatory mechanisms due to the pulmonary hypertension in the presence of hyperextended lungs and the long-term effects of hypoxemic pulmonary vasoconstriction on the right side of the heart. This is what causes the hypertrophy. Hypertrophy meaning that the muscle thickens, reducing the efficiency and elasticity of the heart. Hyperexpansion causes external compression of the heart and lowers the diaphragm with elongation and vertical orientation of the heart, which means sort of it stretches a little bit. Not stretches, you get what I mean. Due to the fixed attachment of the great vessels, because obviously they can't really move, the heart sort of rotates clockwise. The right ventricle becomes a bit more anterior, so it comes sort of towards the front, and the left ventricle becomes posterior, so it goes towards the back. Increased presence of air between the heart and the electrodes has a dampening effect on the amplitude of the QRS complexes, So what this means is that by physically, sort of this elongation of the lungs, physically moving the heart in a way that brings the right ventricle forward, that's how we get our right axis deviation on the ECG, because, well, the axis has changed. Would you believe? You guys are smart. P. pulmonale and right ventricular hypertrophy, they're all fancy words. It's just meaning that the backflow and the inefficiencies of the heart just sort of have their consequences. And funnily enough, we can see this on ECGs. And the next sort of investigation we do is spirometry. I'm going to be honest, I don't know all that much about spirometry because we don't do it in ED. All I know is that it's a measure of lung function by measuring forced expiratory volume. The only time I've tried to use it was when I was on the ward and I got someone to blow into a chibi thing and I recorded how far the little thingy-my-bobby went. And then I recorded it and then the doctors looked at it and they were like, her lung function is fine. I don't know. So how do we treat COPD? We do controlled oxygen administration. Over-oxygenation is a real danger in COPD patients, and this is often a confusing topic for newbies. So I'll get into the nitty-gritty of it at the end, so just before we do chest x-rays. We do bronchodilators and anticholinergics. We often start with what's called a power hour, or hour of power, whatever you want to call it. I call it a power hour. We give 12 puffs of salbutamol or Ventolin, and 8 puffs of ipratropium bromide, which is an anticholinergic, or many people call it Atrovent, in 20-minute intervals for an hour, so 3 doses in total. This helps bronchodilate and helps open up obstructed airways. In severe work of breathing, we may have to use nebulizers. In severe cases where NEBs or MDI, another word for puffers, don't work, we may resort to salbutamol infusions. Yes, IV infusions, or aminophylline. But I've only ever seen a salbutamol infusion once, and I've never seen an aminophylline infusion before. With increased use of salbutamol, a key consideration is monitoring electrolytes, particularly potassium, as high doses of salbutamol drives potassium back into the cell, reducing extracellular concentrations of potassium. That being said, just a little side tangent, in cases of hyperkalemia, so high potassium, sometimes salbutamol is sort of a line of treatment. Not often do we use it because we've got insulin, dextrose and stuff like that, but that can be used. Going back to COPD, you should also be aware of tachycardia induced by salbutamol. Due to compensatory mechanisms brought on by shortness of breath, work of breathing, hypoxia, heart rate is often already high. Therefore, post the power hour, we don't often continue plying patients with salbutamol. Next is steroids. Steroids reduce inflammation and obstruction. COPD patients often take daily steroids but may need stronger IV alternatives to combat the exacerbation. Antibiotics only required if the cause is infective. And personally, I have a bit of a gripe with this one because where I work, it's actually standard practice to give ceftriaxone and azithromycin to all exacerbation of COPD patients, even for end-stage frequent presenters. But I believe the overuse of antibiotics and the risk of antibiotic resistance is high. But this is current practice where I work. I'd love to know, are things any different in your workplace, or is this practice quite, standardized and may require further research and publications to alter? Anyway, keep going. Next sort of treatment option is NIV. And we've discussed NIV quite a few times now, so I won't be going into the nitty-gritty of it. But I suggest if you're getting a little lost, have a look at my Asthma Man episode, or even my previous episode on ARDS, to try and get your head around intubation. Intubation? No, NIV. Oh my god, where am I? Where am I today? Sorry guys. Anyway, I'm just going to continue on. NIV is often used for patients that can tolerate it to reduce levels of CO2 and manage worker breathing plus respiratory fatigue, whilst awaiting other therapies to take effect. Often after a short period on NIV with significantly reduced CO2, patients are stepped down to high flow for ongoing mild pressure support with the flow, humidification, obviously oxygenation if required. But the reason we use high flow for a lot of patients over NIV in the long run is because of the humidification. Humidification is really good for clearing sputum, but it also reduces distress and subsequent respiratory distress from the actual distress. I'm just going to keep going. We have a patient we see often whose ceiling of care is high flow because they cannot tolerate NIV. They've made this very clear. In this particular patient, though, the only times we've used NIV is when they've come in with a CO2 so high that they're practically unconscious. Therefore, NIV won't cause the usual levels of distress, and it gets the CO2 out faster to get them to the point where they can wake up and demand that NIV be taken off. Another point of contention that I'd like your thoughts on, you can leave me a comment, you can send me an email, you can send me a DM on Insta, whatever floats your boat. But another point of contention I'd like your thoughts on. Do you believe it's ethical to place a patient on NIV knowingly against their wishes as an emergency measure to get them away from the brink of death so that they can continue to advocate against it when they wake? It's a tough one to answer. Gotta put on your philosophy hat for that one a little bit, because the easy answer would be no, and then full stop. But I suggest taking a bit longer to think about it. If this was you, how would you want to be treated? Anyway, I'm excited to hear your thoughts, so let me know. And then we get to the big daddy of all treatment options is mechanical ventilation. This is often an extreme last resort and is often not even a ceiling of care for mid to end stage COPD patients. A lot of these patients that are intubated do not successfully come off. Examples of this that I've already mentioned include the patient of my first arrest. She was not a candidate for intubation due to her end stage COPD. Therefore, NIV was her ceiling of care. But if we do intubate a COPD patient, there are very specific settings and parameters we adhere to reduce the risk of barotrauma and ensure adequate recovery. Just as an umbrella thing, the goal of all ventilation treatments in COPD is to reduce CO2, like the partial pressure of CO2 in the blood. So like I mentioned last episode, with patients that have high compliance or high ease of stretch, long, slow breaths are key. Therefore, respirate is slow, inspiratory time is lower, expiratory time is higher, which gives you an inspiratory to expiratory ratio of 1 to 4 seconds. So basically what that means is you're inspiring or you're breathing in for 1 second, and then you're taking 4 seconds to breathe out. This is to reduce CO2, which is what I've been saying this whole time. We choose SIMV over CMV, and for those that didn't listen to my last episode, SIMV stands for synchronized intermittent mechanical ventilation over continuous mechanical ventilation. For the same reasons I mentioned last episode, actually, you should go listen to it if you haven't. This is because continuous mechanical ventilation basically takes over the lungs' job. SIMV allows the patient, once the initial paralysis has worn off, they can actually take their own breaths. But the machine supports those breaths. And if the machine senses that the patient is not going to take their own breath, it will take it for them. Sort of like a win-win situation. They're still getting the adequate ventilation that they need, but they can still initiate their own breaths. And we sort of aim for early extubation in these patients. and normal oxygen and CO2, the usual. We have limits though called permissive hypercapnia that allow for higher levels of CO2 if they still provide the benefits that we are looking for. All these limitations and settings and stuff, they're called, you should Google this if you can, obstructive lung strategy. And for patients without an obstructive lung disease, we use protective lung strategy. All of the sort of parameters and stuff that we set for protective lung strategy, you should go check out my intubation episode. We go through that in a lot of detail. So, common questions that sort of, I don't know about you guys, but these were the questions I had when I was learning sort of advanced COPD. And not even advanced COPD. I remember asking this when I was a grad. And I'll get to the funny story in a second. But the two questions are, why is high CO2 acceptable on VBGs? And how do we tell who is a CO2 retainer and who isn't? And furthering on that, why do we aim for a SATS target of 88 to 92%? How do we tell who this applies to? And how is this even safe? So before we answer these together, I want to take another moment, to discuss the difference between type 1 and type 2 respiratory failure. Now, they sound complex, but I assure you they're not. A funny story again. And I think for the future, guys, every time I say funny story, expect to hear a story that I, for a while, found incredibly embarrassing. Anyway, for my TSP assessment, I was asked, what is type 2 respiratory failure? And I blanked. And then when my educator told me, he goes, it's just respiratory failure with high CO2, I was like, wow, that was easy. But I passed, so it's okay. I'm good. I've gotten over it, I think. Anyway, the main difference between type 1 and type 2 respiratory failure is the level of carbon dioxide in the blood. Type 1 is hypoxemia with normal CO2, which is an oxygenation issue. Low oxygen, partial pressure of oxygen in the blood, normal CO2. Type 2 respiratory failure is hypoxemia with raised CO2, which is a ventilation issue, as we've discussed in quite a bit of depth today. The body cannot clear the CO2. Both are just as dangerous as each other, but moving from type 1 respiratory failure to type 2 is a serious sign of deterioration. So, why is high CO2 acceptable on VBGs? And how to tell who is a CO2 retainer and who isn't? This sort of comes back to the C in COPD, chronic. The body always has a way of maintaining balance, and with the slow progression of COPD, the body becomes accustomed to a certain amount of CO2 in the body. The metabolic system compensates and the pH returns to normal. Therefore, on a VBG, if we see a raised CO2 but a fully compensated metabolic alkalosis, which means high bicarb, we know that this is a long-standing thing. As opposed to myself, for an example, I don't have COPD. If the CO2 in my body increases, the pH will fall, but the kidneys, the metabolic system, will take a few days to even compensate, let alone fully compensate. Showing on a VBG is either an uncompensated or partially compensated respiratory acidosis. So in short, chronically high levels of CO2, which usually aren't terribly high, probably just higher than normal, are acceptable because the body has already found a way to compensate. So how do we figure this out in practice? To know if someone is a CO2 retainer, you will be looking for a slightly higher CO2, slightly higher bicarb, indicating a compensation. With a normal pH, this indicates full compensation. People that are not CO2 retainers will have a normal CO2 and pH, and therefore elevations in CO2 will show up acutely. I'll let you figure out what the VBG for those people will look like, and let me know in the comments if you get stuck. Yeah. And why do we aim a SATS target of 88 to 92%? And how is this even safe? So acceptably high levels of CO2 ties in directly to why we reduce CO2 SpO2 Man, I'm getting myself confused, guys. Don't mind me. Acceptably high levels of CO2 ties in directly to why we reduce SpO2 targets in COPD patients. CO2 retainers are the patients that have in the notes SpO2 88 to 92%, and this is why we do controlled O2 administration. Known as the Haldane effect, over-oxygenating someone whose body has become accustomed to lower levels of oxygen and higher levels of carbon dioxide is detrimental and has a few effects. So the first sort of pathophysiological process that happens is increased partial pressure of arterial CO2, not CO2, pushes carbon dioxide off sort of the hemoglobins because it has a higher affinity, leading to decreased CO2. No, oh my god, I'm getting confused, guys. Let's take this back. Increased oxygen pushes CO2 off the hemoglobin. This leads to increased concentrations of CO2 in the blood. Then, because of the COPD-ness, the body can't clear it, and so it builds up and boom, type 2 respiratory failure. The second sort of process that happens is that increased O2 undoes the vasoconstriction that we talked about earlier to do with the pulmonary hypertension. And by vasodilating the blood vessels in the lungs, we increase physiological dead space and increase the VQ mismatch, or the shunt, whatever you want to call it, which worsens CO2 clearance and boom, worse type 2 respiratory failure. Right in front of you when you're over-oxygenating someone, and trust me, we've all done it. I remember very clearly when I was a grad in ED, I didn't know about this SATS target 88 to 92%. I just thought we were supposed to be aiming above 95. So I over-oxygenated a COPD patient and, well, a CO2 retainer. And luckily I was with one of my educators because they noticed that he was getting progressively drowsy, and then looked at his saturations at 100% and went, whoa, we need to turn the oxygen off. So for you, if you're having trouble with figuring out, am I over-oxygenating? If you are, your patient they'll have a deteriorating conscious state. Your patient will become more and more drowsy, maybe even delirious. And when you do a VBG, the CO2 is actually worse than it was before. But to circle back to the first point, it happens. And the only way you can sort of learn from it and get better is to make mistakes. Just as long as you've got someone nearby to sort of help you, guide you, and make sure it doesn't go too far as to harm the patient in the long term. I also want to make very clear that you may hear the words hypoxic drive. This term is extremely outdated and frankly is a myth. To be fair, I don't actually even know what it means, but it's not congruent with current evidence, which is the Haldane effect and its effect on the oxygen dissociation curve and VQ mismatch. Alright guys, we've been going a while, but hang in there, you can do it. And if you can't, well, I wouldn't know, would I? But I know you can do it. We're going to come back to chest x-ray interpretation. In previous episodes, we've covered in detail ECG interpretation and VBG interpretation. And now to complete the TSP trifecta of greatness, we do chest x-ray interpretation. The key to successfully interpreting a chest x-ray lies in the mnemonic that a lot of people are already familiar with, and that's doctors A, B, C, D, E. But instead of danger, response, send help, airway, breathing, CPR, defib, we look at radiographic criteria. Now, I'm just going to rattle them off to you to practice, but to practice your interpretation, there are websites with case studies, and using this technique will help with diagnosing. But also have a normal chest x-ray up for reference to really highlight the abnormalities. That's what I did prior to going for my TSP patient assessment. And it's pretty effective. One more, I promise, one very, very last point that I want to say before I start is that nursing staff are often only really looking for signs of pneumonia, pneumothorax, pleural effusion, and APO on chest x-ray. But the skill is really good to have, because this is evidenced by my story with the APO BiPAP lady with very fast deterioration. My interpretation of her x-ray in conjunction with my assessments allowed me to escalate to the doctor in charge and start treatment pretty much immediately without her having been assessed by a doctor. So before you say, oh, I'll never need to interpret a chest x-ray, that's up to the doctor. It can help save a life. Yeah. Anyway, I'm just going to start with the mnemonic. This is copied and pasted from my TSP notes. Yeah. Okay. D stands for details. So you've got your name, date of birth, making sure it's the right patient. Your film type. Is it posterior anterior or anterior posterior? Depends on basically which way the photons or whatever x-rays are, they shoot through the body. Is it erect or is it supine? You've got your left and right markers indicating which side of the chest is which. And is it inspiratory or an expiratory x-ray? R actually is another abbreviation. It stands for RIPE. Rotation, inspiration, position, and exposure. Rotation means that when you're looking at the collarbones or the clavicles, they should be in a straight line. If they're not, it may indicate that the patient is not really sitting up straight. Inspiration. So you can figure out inspiration from the number of ribs you can see. I think off the top of my head, it should be, I'm pretty sure it's 8 anterior ribs and 9 to 10 posterior ribs. And then hyperinflation will show a flattened diaphragm. Position, obviously, is the patient upright. Can you see all the fields of the chest? Exposure. So to test exposure, you'll be looking at the sort of intervertebral disc space. Should be able to see up to T4, but I'm going to be quite honest with you, I don't check the exposure. S stands for soft tissue and bones. So you're looking for swelling, air in the subcutaneous tissue will appear as lucency, but normal subcutaneous tissue may actually obscure the view. And the most sort of significant subcutaneous tissue is actually breasts, which shouldn't be surprising, but the more you know. And then bones, you've got your ribs, your sternum, your clavicles. You're just looking for breaks, I guess. Clavicle breaks are usually quite significant. They'll be easy to see. Ribs and sternum, you'd need, unless you're super skilled, you probably need a CT to see those. But as long as they're there, because if they're not there, that would be an issue. Anyway, next. A, airway and mediastinum. So you're going to trace the airway. You should be able to see the trachea, and it should branch from the carina into sort of the two trees, the bronchi. In patients with sort of pneumothorax or tension pneumothorax, on a chest x-ray, as well as seeing the pneumothorax, you may actually see tracheal deviation. So making sure that your trachea is sort of in this straight line is quite important. And then you'll be looking at the mediastinum, so the heart and the great vessels. There's a knob sort of on the right, but then technically the left side of the chest. That's your aortic knob. It should be less than 8 centimeters. And in your chest x-ray tools, probably not at home, but at work maybe, should be able to measure. B stands for breathing. So you're looking at size, symmetry. You're going to trace the outline of the lungs, because you should be seeing infiltrates or patchy sort of small white spots go all the way to the edge of the lung. If you don't, trace that back up and you will have found yourself a pneumothorax. Then you're going to look at the airways, the vessels, areas of increased density. So in pneumonias, you'll find what's called patchy consolidation. So in one specific part of the lungs, you'll find, how do I describe it? Little spots, but greater spots. Yeah. Once you do the tests, you'll get it. And then you're going to look at the borders of the heart, the lungs, and the diaphragm. C stands for circulation. You should see the right atrium and the left ventricle. The rest is sort of obscured by the spine. But you should see 2/3 of the heart on the left of the chest and 1/3 on the right of the chest. Sometimes enlarged hearts take up the whole chest, but that would be an abnormal finding. D stands for diaphragm. The right side of your diaphragm should be higher than the left. It should be a dome shape, and you should see a gastric bubble underneath, so like a pocket of air. And a lot of the times in chest x-rays, you'll just see the top of the sort of abdominal cavity, and sometimes you can see gas in there. The main thing to take away with diaphragm is that it should be a dome. In COPD patients, the diaphragm is often sort of flat. This is because of the elongation. And then E stands for extras. Any extras you can think of. Lines, devices, tubes, trains, drains, ETTs, central lines, NGTs, intercostal catheters, pacemakers, sternal wires, hemostasis clips, foreign objects, and ECG leads. Now, to head back to the topic of COPD, the main things we'd see is a very elongated chest, barrel chest. I didn't actually mention costophrenic angles. I really should have. It should have been in my little TSP list, but that's fine. The angles at the edge of sort of the bottom sections of the lungs sort of come to a point. If you have a look at a chest x-ray on Google, you'll find the point. That's called a costophrenic angle. In a normal chest x-ray, you should have a pretty decent angle because then it comes up and sits on the diaphragm. But because the diaphragm is flat with people with COPD, your costophrenic angle becomes more like a right angle. And that's what we call a blunt costophrenic angle. So seeing those sort of widened angles indicates COPD and sort of goes hand in hand with a flat diaphragm. So that's chest x-rays for you. I'm sorry I sort of just rushed through that. I'm conscious that I've been going for a really long time. But COPD is a behemoth of a topic. Never actually realized that. Maybe I subconsciously realized that, and that's why I have avoided trying to write the pathophysiology down for years now. It's all really starting to make sense. Now, I did say the last point was going to be the very last point, but I promise this is the very last, very, very, very last point I want to mention, and it's very, very important. If you take anything, one thing away from this episode, let it be this. While hypercapnia can kill, hypoxia kills faster. So do not delay administration of oxygen in fear of hypercapnia. So if you've made it this far, well done. COPD and chest x-rays are no easy topic. Despite how often we treat and see these patients, by knowing the ins and outs of the condition and how it works, it's easier to understand and remember why we do certain things, like NIV and high flow, and why we avoid certain things, like over-oxygenation and intubation. I hope my explanations have been tolerable and that you've taken something away from this, along with the multitude of questions I've asked. And I really would love to hear your thoughts. If you don't want to comment, send me a DM on Insta or shoot me an email and I'll get back to you ASAP. Zero judgment and ready to share knowledge. Now, that wraps up, finally, this episode of my show, Chronicles of a Learner RN. I've certainly sort of not really learnt a lot, but it's sort of, It's brought that sort of knowledge forward. Knowledge that I keep in the back of my mind, but I don't really have time or opportunity to think about in detail. But I hope you have learned something or this has had a similar effect for you. I've got a plethora of cases and learning experiences I'm excited to share with those of you that are willing to listen. If you enjoy what I do, what I say, and what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Thank you, and see you next time.